Dear chairpersons, dear colleagues, first of all, I would like to thank the organizing committee for the kind invitation, and it's a great pleasure to be here again in Egypt and to have the opportunity to talk about single retro inner branch by custom-made TVAR. So my disclosure, actually I am thrilled to announce that since 24, I have started my new role as Director of Vascular and Endovascular Surgery at PAVSS Hospital, University Medical Center, Oldenburg. So I moved from Mainz to Oldenburg. Back to the endoleak. Endoleak type 1A is a serious complication after TVAR and represents a significant challenge for all of us vascular surgeons. Has an incidence up to 20%, and rapid detection and treatment of these kinds of complications is essential to assume patient safety and prevent serious complications such as rupture. In TVAR, landing zone 3 and 1, as by Ishimaro classification, increase the risks of type 1 endoleaks, as landing zone occurs in a curve. I mean here the proximal part of the stents, which is landing in the curve in the proximal part of the aorta and the distal part curve in the aorta. And it's important to mention also that the 30-day mortality is up to 20%, and also the classification distinguished between primary symptomatic and asymptomatic, and also between primary and secondary, where primary, the endoleak is directed intraoperatively detected or in the first 30-day after operation, whereas secondary in the remaining follow-up period. Within this classification, there are fast flow type 1 endoleak and slow flow type 1 endoleak. Actually, this classification is very important. Why? Because as you can see here, the slow flow endoleak type 1A seems to have an increasing of self-resolution. As you can see here, 70% of patients with slow flow endoleak type 1A have to resolve spontaneously in the first 1 year after detection. That's why a conservative treatment seems to be reasonable by such patients. So, conservative treatment involves monitoring of the patient's blood pressure, heart rate, and giving medications such beta blocker and calcium channels blockers may be effective by reducing blood pressure and risk of rupture. For the surgical management, we have the direct closure of the endoleak, actually, which has not been performed for a long time, forgotten. And as second choice of the surgical management, we have aortic arch repair, such as elephant trunk or frozen elephant trunk with a Russell. When we go about hybrid management of the endoleak type 1A, we are talking about the branching of the supraaortic vessels or kind of bypasses. I'm talking here about carotico-carotico or carotico-sclevian bypass, following with a TVAR either simultaneously or as a stage operation. For the endovascular management, as you can see here, we have the embolizations such as Onyx, which has a good actually results for type 2 endoleak, but no reliable data for type 1, especially after TVAR. The chimney technique, but as you know, we have here increasing risk of re-endoleak with an incidence up to 40% because of gap between the chimney and the proximal part of the stents. and that double and triple branch has a good results with a re-endoleak incidence of 2%, but here we should know that this kind of operations has also limitation, such CABG, prior CABG in the ascending aorta, or such as aneurysmata for more than 45 millimeter in the ascending aorta. Actually, also, we should not forget that with this kind of operation, we are proximalizing our problem and we are landing with our reconstruction new stents graft in the ascending aorta, and that means increasing of such complication like retrograde type A dissection. I would like to present a case for today, a 77 years old patient, multimorbid, with history of CABG, 3 CABG, Lima LAD, and 2 venous CABG from the ascending aorta to the CX and right coronary artery. This patient underwent a TVAR in zone 3 after by penetrating aortic ulcer, and after 4 years, a contrast-enhanced CT angiography reveals a fast flow asymptomatic type A endoleak. So actually, in MINDS, what we do, or in Oldenburg, we go for proximalization in zone 2, TVAR and carotid-subclavian bypass. But here, the preoperative diagnostic reveals a stenosis of the left common carotid artery and big plaque at the upgang, at the uptake of the common carotid artery. Otherwise, don't forget that the patient has Lima LAD and 2 bypasses from the ascending aorta. So here, as stenting TVAR in zone 2 is not possible, and for double branch or triple branch in the ascending aorta landing is also excluded. That's why we thought about landing zone 1 with a TVAR, with covering the both subclavian, left subclavian artery and left common carotid artery, with a single branch retro to the subclavian artery and subclavian carotid bypass. Therefore, we decide a custom-made TVAR covering the both arteries and in a branch retrograde with a wide of 9 millimeter and length of 35 millimeter. And you can see here the additional left the bypass or the stent for the subclavian artery, and following by left subclavian to carotid artery bypass. As you can show here, with 80 millimeter Dacron prosthesis, we perform these bypasses infraclavicularly, as we wanted to avoid the mammary zone, considering as a sacred zone. After the bypass, simultaneously, we performed a deployment of TVAR in zone 1, covering the subclavian, left subclavian artery and the left common carotid artery. Subsequently, then we implanted a VBX from Gore, 10 millimeter wide with 59 millimeter length in the artery subclavia links through or into the retro single branch. And the entire operation was performed via a percutaneous puncture approach. Here you can see the post-operative control CT, conferred complete exclusion of the endoleak and patent subclavia to carotid and Lima bypasses. So operation time was 250 minutes, contrast was 90 millimeter, and the patient was discharged after 5 days, and we have till now follow-up of fast 2 years. Our plan in Oldenburg to manage post-operative TVAR endoleak type 1A is by symptomatic. We opt to revision. By asymptomatic and intraoperatively, we opt also for direct revision. By asymptomatic in follow-up period, by faster flow, we opt for revision and operation. By low flow, control medication. As conclusion, after TVAR, a long-term CTA follow-up is required for type A endoleak, can occur at any time, and further advancement in endovascular surgery are needed to expand the possibility to treat such complicated cases. Thank you for your attention.